what I'd like to do then is to actually set the scene on work disability prevention, is to introduce our first speaker, Patrick Loisel. I've known about work disability prevention, Patrick, for a long time, and I was very, very fortunate to be part of the CRHR training program that Patrick invented, funded, and continues to run. And everything I know came from that, and so I'm not blaming it for my lack of knowledge, but and I've touched base with Patrick over the years, and so I know that he has the information that we need and the passion to move it ahead, and so I'd like to introduce Patrick, who's going to give us an overview.
Thank you very much, Richard, for this very nice presentation, and I'm very happy to be here and to see this audience, you who are really working in this field, in this difficult field, and you have a lot of experience. It's not newcomers in the field, there are people that know it, and will know a lot of things that I will say anyway. But perhaps it's, I will try to bring a scientific approach, what the science has taught to us in work disability prevention, which is a recent science, because it was, I think, 30 years ago, there was very little in work. People were even thinking at work disability prevention, except a few people what thought about this. So I will try quickly to bring together the knowledge, and in my view, the way we have grossly to do in order to make this knowledge implemented. So Untitled that advances in work disability management, the need for a standard. So always a problem of the, I think it should. Yes, that's better. So what happened? As has been told, I am running the Work Disability Prevention CRHR training program for just 12 years. The program goes to an end now, but it has trained more than 100 trainees from around the world. And Amin is part of the training program. He's been a trainee there. And one day during the session, he came and see me and told, I got an idea. So I'm very happy. So I am very happy you had an idea. I love that students have ideas, and this is what we wish. So he brought me the idea as and the idea was, as from his engineer background. Why? Because I learned that the knowledge, you have the knowledge, this is not applied. But if you want it is applied in workplaces, it needs to, we need to have a standard, because workplaces are running their business through standards, many of them. So what a bright idea. And this has begun like this. It's not my idea, it's Amin's idea. And I tried to push that. Obviously, we went and CCSA folks and Ron, and then because I was knowing absolutely nothing about standards, and I learned some just basic things, and I really think it is a rich idea. So I want also to give you the definition of work disability. I have edited with colleagues last year the first, I think, handbook of work disability, which is just a handbook that speaks about work disability, whatever the disorder. And we have named prevention and management. And since it is you, that it is not treatment, it is management. Work disability is occurring when a worker is unable to stay at work or return to work because of an injury or a disease. Work disability is the result of a decision, and look at the decision between quotes, by a worker who for for potential physical, psychological, social, administrative, or cultural reasons doesn't return to work. It's always a decision because you can always go to the workplace. You take just an ambulance and you go to the workplace. So it may be difficult, but you can go, theoretically. You decide not to go because you are so afraid of joining the workplace. It looks terrible for you with what you feel to go back to the workplace for just a lot of different reasons. And while the worker may want to return to work, he or she feels incapable of returning to a normal working life. And what we have learned these past 25, 30 years is that the determinants of work disability has nothing to do with the disorder who has triggered the work disability. Certainly there are some biological factors, the medical status, physical capacity may have a role, but generally a very small role. The most important factor are the psychological factors, which are fear, anxiety, motivation, and depression. It's not that these guys are insane. It's they are fearing. I break my leg, and I'm fearing of what happens. Am I insane to fear? No, that's normal. That's normal reaction of human beings. So these psychological factors are also determined often by the social factors that influence the behavior in two ways. First, because they can make difficult to return to work, and so they can make the worker is afraid. I remember a lot of patients coming back to me with a letter coming from their insurer, whatever, public or private, and telling, oh, doctor, can you tell me what it is? I don't understand what is written down. So I took the letter, and I didn't understand as well. So you see this relationship, this is a social factor. And we have just a lot of good, but side effects. And a cultural context that makes this problem exist worldwide, and with a lot of differences depending on countries and provinces. And we know that in our country we have 10 provinces, 10 workers' compensation board, and 10 ways of doing the same thing. We have also this model that is very useful about the pain, because one of the problems, especially for musculoskeletal disorder, is all patients who don't go back to work have pain and say I am having pain. So after an injury, depending on what you feel and what you think, and you will have two ways of going. You may have no fear. You confront the reality with your pain, and you say, it's just small pain, I don't care about that, and you recover. So 90% of people go this way. But there is a small number that catastrophize, because they have a negative affectivity, they are threatened by things, etc. So these fears make that they go to catastrophizing, they have pain-related fear, leading to avoidance, hypervigilance and disuse, etc., and they run into a vicious circle, and that impeds them to go back to work. So this has been, from a researcher in the Netherlands, a very useful one, model. So do we have to speak for back pain and also other disorders, or of back pain or prolonged work disability triggered by back pain, or triggered by arm or shoulder pain, or triggered by depression, or triggered by a lot of other disorders. So the life prevalence of back pain, for example, is more than 80%, which means that every one of us will have back pain one day. Unfortunately, I have to say this to you. If you didn't have, you will have soon, one day. But it should not be terrible, because pain level depends on the perception of the causation. What has caused? If I think it's from my job, I'm not happy that this job has given me back pain or other pain. The meaning, and we have made research that makes that people think this pain is normal, or maybe abnormal, something disorder, so or necessary. I do have pain in order to it improves my condition. So the treatment is painful, but it's needed. It can be reconstructed. This is a new way to see the pain after a treatment or a management. It depends on the consequence, risk of worsening while resuming activity. If the worker thinks for any reason that going back to work would get him paralyzed, for example, so it's very, very clever not to go back to work, obviously. This is a false assumption, but you behave the way you think. And a very interesting and important thing that has been demonstrated recently by my colleague Mick Sullivan is the perceived justice. Human being cannot, injustice, we cannot, we don't like that, but not only it's too, I don't find the term, but it's really bad for us. And if you think that you do not receive a fair management of what you have, it is also a reason for not going back to work. So an accident or disorder may trigger a cascade of effects that are not looked at most of the time, and fortunately, especially by doctors. Because when I was just doing my medical training, I was told that, especially in orthopedic surgery, where a patient who has a pain somewhere starts to speak about other things, you have to bring back to the problem and see what it is exactly. And so when I was a young orthopedic surgeon, it was terrible for me when a patient was telling me, when I asked, where is your pain? He said, I have pain everywhere. Some patients come and say that. So imagine an orthopedic surgeon cannot make an intervention everywhere. So it's a problem. But now I'm very happy a patient tell me that, because it is a starting point for going to the true reason of his problem or her problem. So pain, fears, anger are normal psychological reaction. There is also, with absence of work, a change in relationship with the employer, because the employee is not part of the production, but part of the problem. There is new actor to deal with. Healthcare providers who may have various roles, healer, gatekeeper, expert, etc. And insurers, they know they are insured, but they don't think about that, obviously. So they have to deal with people from the insurance. A lawyer, if there is the case goes to appeals. And there are often a lot of delays to the system and uncertainty and diagnosis. And I can tell you that I've been sick recently. And during the time you have to wait for your exams and you don't know what is the real thing, you are really afraid. It's terrible. It gives you anxiety. And it's a normal reaction. You cannot blame that. And also, looking at the disorder, you have many, many specialists that the worker who don't find a solution, he goes around. He's just ending to the fortune teller to try to. So this is just terrible issues. So work disability is not the disease. And this is what we have found during a lot of research that has been done this past 30 years. Work disability is not the disease. It is completely different. It comes out from one disease often, but it is not the same thing. It has different determinants, different issues, different players, and that needs a different management. So, in summary, work disability results from inappropriate actions and interaction occurring in this multipartite system involving several stakeholders interacting with the patient during the disability process. So, as I told you, I ran this randomized clinical trial in Sherbrooke with randomizing workers to having back pain to standard care, clinical intervention, that's the best that we had at the time, and occupational intervention, that was completely new for me, just with ergonomics and occupational medicine counseling. And the Sherbrooke model, as we name it, was an addition of clinical. And this was very interesting to see. The bars are a statistic would give the speed of return to work. So the speed of return to work was, you see, clinical intervention, even it was the best rehabilitation intervention at the time, did nothing. And occupational intervention was effective. And for me, an orthopedic surgeon, it was quite a surprise, I can tell you. And interestingly, adding the two, a clinical approach added to a workplace approach was effective and extremely effective, and also effective and the functional status, as you see with this questionnaire, you see extremely effective and functional status, and the control group, this was at the start, the control group was not improved really. And the costs, 6 years later, we reopened the CSST files, and we found that the intervention were effective, in fact, but the most effective of all was the full intervention Sherwood model. Interestingly, this has been adapted, this model by a colleague, Anna Neymar and his colleagues, to the Dutch situation. And a completely different system, extremely different system than the one we have here. You see, it's another way to present the things, but this is also the speed of return to work. And you see that this model, adapted to the context of Netherlands, was effective with comparison with the intervention group, and extremely cost-effective also. You see, every euro invested in integrated care returned 26 euros, which is not bad investment, obviously. So in 2010, Carol, a researcher, made a review of effectiveness of workplace interventions, because these interventions in the workplace, with different ways of doing it, have been repeated and tested by other researchers. So the review of this by Carol is 9 control studies, including 8 RCTs, for the same back pain population, intervention involving stakeholders working together without any exercise component appear to be more consistently effective at helping people to return to work. So you see workplace intervention work. And it is very, very important to have, yes, there is some clinical or some other psychological help to bring, but the workplace, because the worker fear to return to the work. If we explain the worker that the workplace, and if you ask the workplace to accommodate nicely the worker, return to work is just generally what happens after that. So it's a social solution for treating work disability. Again, work disability is not a disease. So with our team, we developed this, this comprehensive model that showing that a worker with a work disability has to deal with himself or herself from the physical, the emotional, the cognitive, and the social relationship side. So a worker is a person who has just a lot of problems. He is happy or unhappy in his life. But also the workplace was at the different levels of, from the job to the big figure of the organization as an influence. And because the workers was part of the production and becomes a problem being absent. There is also the insurance system with all the legislative things that get around that have obviously an influence on the behavior and the way the case will go, and also the medical or the healthcare folks, so that we also have an influence, and if we can. The worker is very anxious. You see, I've seen that. But the X-ray, you put it in the light, and you see things. And the worker is very anxious. And your face is very important when you are a physician. Because if you feel, oh, like this, the worker says, oh, when will I die? And if you see, you have an X-ray of the spine, but around before the spine there is the intestine and the gas in the intestine. It appears as a spot, a large spot on the. So I have many workers saying, "Oh, doctor, this large spot, what it is on my spine." So it is not. It's your intestine. It's normal. So. But if they are not explained, they have this in their mind. So anyway, this is, and this depends also of the society and the culture and politics that rules around. So what we have seen very important, that these different players from these different sides generally have different aims, different views, different understanding of the situation, and don't work together. They need to work together. It is very important that these different parties. It's difficult because you see they have different interests and different views of the problem. But it is fundamental that they work together in order to, because all players, they are not bad apples. All players have legitimate objectives and have to play their game. The worker is afraid of disorder, which is normal, and want to heal, but may think that the movement will aggravate the disorder. The employer has the responsibility of the production. If the company goes to bankrupt, it's not helpful for the worker as well. The union has to protect the worker, but also the whole workforce. The insurer gives compensation, but he doesn't have to go to bankrupt anyway. And the care provider have a responsibility and knowledge to try to make a diagnosis, the right diagnosis, and heal the disorder. But most of them have very little knowledge in disability and workplaces. Because in the medical school, it's not taught. There are so many things to teach in medicine. And this part is not taught to most healthcare providers, except if they are going to specialize in occupational medicine. So you ask them, I heard about, oh yes, the notes, the fit notes, the sick notes, all these notes. But the worker don't know what. When I was an orthopedic surgeon before doing this job, when a worker was bringing me something, oh doctor, for light work, can you tell to write what I can do? So I was asking the worker, what can you do? Because I was knowing nothing about his job. So, and I was just writing what the worker was telling to me. So it would be more simple and less costly that the workplace ask directly to the worker, what are you able to do? And rule out the things themselves, because just I don't know. And so you see, it's like a soccer game where there is, all the players have different rules. So it cannot work. But this is the arena where we are in work disability. Different players with different rules trying to play the game. So we developed the Prevalence program was from the evidence of the Sherbrooke model and others to make a diagnosis of work disability first. And then we have named it Therapeutic return to work, which is a process, progressive management with the workplace and other partners to go back to work, returning to regular work. And it has been assessed by another university. And you see again that the return to work was quicker than the control group from the patients that were sent to us by the CSST. It was not a randomized trial, but a matched case control study. It is published by the RSST as well. So work disability is not the disease. Being at work depends on a fit between a worker and a workplace, skills, values, culture, organization, etc. So work rehabilitation is not a medication nor a standardized intervention. It cannot be standardized because each worker has a problem which is different from the other. Conceptually it's the same, but practically it's different. And work retention and return to work require maintaining and restoring the fit between the worker and the workplace. So it's important to investigate the perceived or real obstacle to return to work. Not the disorders. The disorder is for the treatment. But you see all these kind of things that I was saying. And also the facilitators for return to work. But because hopefully, if a worker has only just obstacles, it will not work well. But most of them are these facilitators that you have to know in order to help them return to work, because they can help you. The family might be helpful or unhelpful, depending on, so you may have to meet them as well. And there is a major influence of policies. So this is from a very interesting, important, and thoughtful report from the OECD 2010, that telling the good news on which further structural reform should build is that policy matters. Countries which embarked on comprehensive reform involving both the benefit and the employment support system have seen the biggest changes in outcomes. And I think standards are part of policies, and this is very important. So for helping return to work and work retention, we have to think in a different way. We have to forget the medical model. Not that the medical model is a bad model. It's excellent for the treating disorder. But it is absolutely not useful and not good for work disability. So we have to think in a different way. And this is why we need, because everybody thinks through the medical model, the workers, the patients, everybody in the streets, not only the physicians. So it's really a mind shift that is needed. And these standards, I think, may bring help for the mind shift. So you see, we have the solution, we know what to do, but it is not used. And this is a problem that we have. And people try to do the thing, to run this cart with square wheels, which just not very good, obviously. So standards for WDP management, I think, will guide the workplace actors and the other stakeholders for an early, appropriate, reliable, and coherent management of work disability. So, thank you.